So when we look at our signs and symptoms or our clinical manifestations, there's a whole list of potential signs and symptoms. The thing with that is they're so small, they're so minor that we tend to miss them. And when that happens, we sometimes think that it could be a different condition before we even think about this one. So one of the things that I want you to really recognize is this is a sudden change or a sudden experience of shortness of breath. So when we start to have that sudden experience of shortness of breath, that I want you to kind of put that in your hat and to be thinking about a PE anytime that you have these sudden changes. Now, there are a number of different arrhythmias, and we will talk about different arrhythmias specifically in your EKG class, but what we call sinus tachycardia. Anytime that you hear sinus, that means normal tachycardia, and you guys already know what tachycardia means. Atrial arrhythmias, you'll have atrial tachycardia, atrial flutter, atrial fibrillation. You can end up with right bundle branch blocks or peaked P waves, which is what we call a P pulmonale. These patients are going to present with a weak pulse. They're going to be lightheaded or they'll faint. They'll have anxiety. They'll be excessively sweaty. Cyanosis, specifically, this cyanosis is going to be from the nipple line and up. Nipple line and up. They're going to have cool or clammy skin to the touch. They're going to have some chest pain. So when we look at the chest pain, this is going to resemble a lot like a heart attack. It could be radiating to the shoulder, the arm, the neck, or the jaw. The pain is often described as like sharp or stabbing, aching, or even dull. The pain often intensifies when the patient inhales deeply, coughs, eats, or bends over. And the pain intensifies during exertion but may not go away completely when they're at rest. So a number of different explanations or a number of different adjectives that they could use when it comes to the chest pain. There's going to be a cough secondary to that AC membrane being flooded with red blood cells. You could have red tinged or blood streak sputum. You could hear that high-pitched cardiac wheeze. You could even have some fine crackles with that as well. A lot of times you'll see leg swelling. You'll see an increase of respiratory rate secondary to the hypoxemia. Breathe more, beat more. And then from that, you're going to get a stimulation of your peripheral chemoreceptors, increasing your respiratory rate. The patient's going to have a decreased PaO2 because oxygen will not be able to diffuse. We have dead space that's taking place. You have ventilation that's taking place, but you have no blood flow to pass through that alveoli, so perfusion decreases. When the perfusion decreases, your PaO2 will decrease. When your PaO2 decreases, your SaO2 decreases. When your SaO2 decreases, your CaO2 will decrease. Woo! Lots of oxygen that is decreasing, especially with these pulmonary emboli. And we see that there's going to be the reflexes from your aortic and your carotid baroreceptors that are going to increase that heart rate. So we see there's an increase in alveolar dead space. We see that there's an increase in alveolar dead space. There's the reflexes from the aortic and the carotid baroreceptors that aren't getting as much blood flow and aren't getting as much oxygen, which are going to increase that heart rate and increase that respiratory rate, causing that patient to maybe experience some anxiety, some lightheadedness, or even fainting. So lots of craziness when it comes to the signs and symptoms, and we're not done yet. So as we remember that when the respiratory rate increases from the hypoxemia, from the peripheral chemoreceptors, from the irritant receptors, from the carotid bodies and the aorta bodies, recognizing that the blood flow is decreased and the level of oxygen that the blood flow, or that is in the blood flow that is, passing through those checkpoints, it's going to stimulate an increase in their respiratory rate. All of those factors lead to an increase in respiratory rate. And if we have dead space that's happening, we have we have ventilation that's taking place, but you have no perfusion. Then you have oxygen and you have carbon dioxide that is sitting in the alveoli, but it has no blood flow to drop off or pick up when it comes to those molecules. And the faster that patient breathes, the more dead space that we will see when it comes to taking care of these patients. So very quickly, the faster that they breathe, the more tachypnic that they get, the more struggle they will have because of that physiologic or alveolar dead space. So we see that, and whenever you have an increase in that hypoxemia, you're going to see breathe more, and you're also going to see beat more. We're going to get an increase in our heart rate, but the downside is, remember, we have a blockage of blood flow between the right heart and the left heart. And that blockage is going to decrease the amount of traffic. It's going to decrease the amount of blood flow that gets from the right side of the heart over to the left side. And if we have a decrease in blood flow to the left side of the heart, that's going to lead to a decrease in the blood pressure as well. So when we have a severe obstruction and we see left ventricular stroke volume, the left ventricular stroke volume decreasing, this is an ominous sign, or an ominous sign is a very, very bad sign. So when we start to see this patient's blood pressure decrease, look out. They are about to code, and we need to take care of this patient right now. So when we look at this decrease in the blood pressure, it actually reduces the tension of the walls of the aorta and the carotid arteries, activating those baroreceptors. And that activation of those baroreceptors, again, increase the heart rate and increase the respiratory rate, creating more issues than when we started. You're going to see an increase in your J receptors, the juxta-alveolar receptors firing off. That increase in vital signs, the heart rate and respiratory rate, is going to cause some anxiety. These patients are going to feel fear. They're going to feel uncertain. They're going to feel unsure about what's going on. All they know is they can't breathe, and they need somebody to help them breathe right now. You're going to see peripheral edema. You're going to see venous distension, particularly JVD. You'll see some JVD. You will see an enlarged liver. You won't see that, but you'll be able to palpate that. The peripheral edema will also include ankles and feet. You can have pitting edema. Patient will complain of chest pain like we talked about before. You're going to get a diminished blood flow to the brain. When you get that diminished blood flow to the brain, that will cause lightheadedness, that'll cause confusion, and even these patients can pass out or have syncope. You're going to have abnormal heart sounds. Patient's going to show up with pulmonary hypertension secondary to that pulmonary vascular resistance being really, really elevated, like super elevated. We're going to see right ventricular strain. That right heart is going to have to work harder to overcome the afterload of the peripheral vascular resistance, or the PVR. You're going to have ventricular hypertrophy, which means that that right heart is going to swell. You're going to see that right heart swelling, and you're going to have potentially mixed crackles or fine crackles and wheezing. And you will also hear a pleural friction rub with this patient as well. So there are some telltale signs of a pulmonary embolism. Definitely this central cyanosis that has a line at the nipple line and up. This is a telltale sign of a pulmonary embolism. This is a massive pulmonary embolism, and we need to do everything that we can to take care of and intervene for this patient before they get to this point. So all of those other signs with the heart rate, respiratory rate, blood pressure, again, we're managing the trends. We're navigating the trends. We're not only looking at that snapshot of what you see right now, but what has it been over the course of the past few hours. So when we get into diagnostics and screening, there are some specifics when it comes to a PE as to what we will use for diagnostics and screenings. And we're going to look at several different blood tests. We're going to look at imaging, and we'll talk about a few different imaging like CAT scan, chest x-ray, MRI, MRA, VQ scan or ventilation perfusion scan, and ultrasound. And then there's this modified Wells scoring system. This is a predictive tool that we can use to look at the clinical probability that this patient will have either a PE or a DVT. So we'll look at those. The first test that we're going to talk about is a CBC. Remember, we've talked about the CBC before. This is your white blood cells, your hemoglobin, your hematocrit, and your platelets. Increased red blood cells or polycythemia is a risk for pulmonary emboli. Look at the CBC. Do we have polycythemia? We're going to look at what's called clotting times. We're going to look at the PT, PTT, and the INR. For now, just know what those are. So if I say clotting times, I'm talking about the PT, the PTT, and the INR. And sometimes that PTT is labeled the APTT. Clotting times, PT, PTT, and INR. We're going to look at screening tests that looks at the erythrocyte sedimentation rate, renal function, liver enzymes, electrolytes. But the one that stands out, the one that I need you guys to know, is the D-dimer test. The D-dimer test is a test that you will do or you will recommend for a patient who you suspect having a pulmonary embolism. So when we look at this, this is a fibrinogen test, and it checks for an increased level of protein fibrinogen. It's an integral component of the blood clotting system and that whole factor that goes into clotting. And you can get these results relatively quickly. It's less than an hour that you can do this. In some facilities, they have little cartridges that you can inject blood into, and you slide that cartridge into like a tablet, and it'll analyze it right then and there. So you can get it really, really quick. Go ahead and put a circle right here. Values greater than 500 nanograms per ml is considered positive. When you have a D-dimer that's positive, that suggests that there is a clot. That suggests that there is a blood clot. Other conditions can increase that D-dimer, like recent surgeries. And the D-dimer is really so that we can have supplemental or additional information on top of what we already know. Normal D-dimer rules out the possibility of a blood clot. So if my D-dimer is normal, then I can safely say that that patient does not have a blood clot.